So yes, definitely kidneys and lungs would share many similarities, and I agree a lot with what you just said. Thank you very much to the ISFAR organizers for inviting me to talk today about pulmonary protection in the perioperative settings and what could be some myths and some facts about it. So I do not have any relevant conflict of interest with this presentation. And the first myth I would like to discuss is the false feeling that maybe pulmonary complications after surgery may not be so frequent and may not be such a big problem to patients. We know actually that the postoperative period is a very risky time. And since this USOS study, international study, almost 10 years ago, we know that almost 4% overall of surgical patients would die in the hospital. And among complications in general, pulmonary postoperative complications are very frequent, especially after major surgery, thoracic or abdominal surgery. And for example, the need for reintubation because of acute respiratory failure after surgery is associated with a higher risk of death in the hospital. So that's a big problem. But hopefully, we are now more and more able to identify those patients who are more likely to develop postoperative pulmonary complications. And multiple scores have been suggested. This one, the ARISCAT score, and there's been also the more recent Las Vegas scores, but they are both very similar. Another myth I would like to discuss is that maybe intraoperative lung protective ventilation could be just about setting a low tidal volume. We know the book of the law now of 6 to 8 ml per kilograms in ARDS in the ICU. And of course, there are multiple evidence. We know this since a long time now that using lower tidal volumes is independently associated with decreased postoperative respiratory complications. But actually, there has been this more recent trial published last year, this Australian single center trial of 6 versus 10 ml per kilo predicted body weight for tidal volume in both groups ventilated with a PEEP of 5 centimeters of water. And there was strictly no difference in the risk of developing postoperative respiratory complications in this trial. So that was kind of surprising. However, we already knew actually that manipulating tidal volume alone may not be enough to protect the lungs, and that it could not be enough to avoid some pulmonary complications such as atelectasis or ARDS. Therefore, it might be more efficient and important to combine multiple interventions on our ventilators, such as combining low tidal volumes, a certain level of PEEP, and the application of recruitment maneuvers to improve postoperative outcomes. This was especially true and shown by the IMPROVE trial by Emmanuel Fitier and colleagues, in which the intervention of lower tidal volume, a PEEP around 6 centimeters of water in this trial, and regular recruitment maneuvers were associated with less complications, at least during the 7 days after surgery. In particular, this approach in the IMPROVE trial was associated with lower values of inspiratory plateau pressures and increased respiratory system compliance. And these parameters, we now know that they are useful to estimate the driving pressure, which is probably more directly associated with ventilator-induced lung injury, and in particular during surgery, it is associated when increasing with a higher risk of developing pulmonary postoperative complications. Therefore, our approach to PEEP and recruitment maneuvers during surgery should mainly be aimed at increasing the compliance of the respiratory system while decreasing the driving pressure. And although the prospective use of this strategy still warrants validation in clinical trials with regards to postoperative outcomes, there is already this pilot trial published last year in which this strategy was associated with less inflammation, less systemic inflammations in patients. So we're waiting, of course, more validation of this more personalized approach. But of course, and this will be my myth number 3, you know that lung protection, perioperative protection is not just about intraoperative ventilation. And there are, for example, multiple areas of improvement for the preoperative status of our patients that are directly linked to their outcome after surgery. And an easily accessible, let's say, intervention is, of course, smoking cessation at least 1 month before surgery, and other areas for prehabilitation. In addition, the use of non-invasive positive pressure ventilation is particularly beneficial in at-risk patients, both before surgery, during pre-oxygenation, for example, and also after extubation. And this will impact outcomes in at-risk patients, at least. There are many evidence now for these positive pressure approaches. Of course, how we manage fluids, for example, during surgery will also influence the risk of developing post-op pulmonary complications. The more fluids, the more complications. There is at least one, I guess, wonderful session today during the ISFAR about intraoperative fluid management, and it will be very interesting to follow. But the risk of respiratory complications, we know a lot about this now. And as for intraoperative ventilation, the best always it would be to personalize fluid management to the needs of each patient, based, for example, on the monitoring of systemic stroke volume, as it is recommended in major surgery and in at-risk patients. So maybe also other interventions can be useful. This has to be validated, of course, but for example, the choice of analgesia, the use here, for example, of epidural analgesia for aortic, abdominal aortic surgery, has been associated with decreased risk of postoperative respiratory failure. And the choice of the anesthetic agent could also possibly influence some postoperative respiratory outcomes. There have been some contradictory reports, but at least this meta-analysis in patients after cardiac surgery, not in other kinds of surgeries, but volatiles were associated with reduced postoperative pulmonary complications in some studies. Of course, there may be other promising perioperative interventions, such as corticoid therapy, for example, that might decrease inflammation and hopefully improve post-op respiratory outcomes. And we are waiting now for the results from this PACMAN trial, for example, led by Karim Azenoun. And as you understood from my talk, I hope so, all these interventions to decrease complications, they must be best integrated in a larger framework, multidisciplinary approach to rehabilitation, both before and after surgery. And of course, anesthetists, intensivists have an active role in this bundle, let's say, but this is mainly very multidisciplinary. We should also keep in mind that every piece of the chain is crucial. And for example, interrupting sedation just after surgery, immediately after surgery, even in patients with organ dysfunction, this has been associated with improved outcomes in the SOS ventilation trial from from you, Gerald. So this is also things we have to always remind that every step can have major influence on the outcome. So to conclude, postoperative pulmonary complications, they are frequent. We now know, hopefully, how to identify patients most at risk, and so we should be very cautious in these patients. Not everything in the postoperative period is about respiratory complications. You should also have in mind surgical complications that would require specific treatment, surgery, and antibiotics, for example. For intraoperative ventilation, these are the recommendations published in 2019. You should set a lower tidal volume, a PEEP of at least 5 centimeters, and recruitment maneuvers could be performed. In mind, you should keep that the goals would be to increase the compliance of the respiratory system, to decrease plateau pressure, so to decrease driving pressure with these interventions of PEEP and recruitment maneuvers. And you should always monitor, of course, the patients. About FiO2, I didn't really mention it, but the recommendations are that you should target 0.4 or less, or at least the lowest FiO2 to reach a pulse oximetry of 94% or more. All these interventions, are included in a bigger framework, so everything is important in these bundles, identifying at-risk patients, positive pressure ventilation as needed, and the multidisciplinary approach beyond anesthesia itself. On this, thank you very much, and I'll be happy to discuss and take any questions.
Thank you very much, Mathieu. Great talk also. And thank you for reminding the very clear guidelines at the end of your talk. And I don't think that everybody really pays attention to the minimal FiO2 and keep a very small FiO2. What do you think about it?
Well, I can understand it because there have been reports initially of high FiO2 being associated possibly with less surgical site infections, at least in colorectal surgery. But there are concerns about high FiO2 in general because of oxidative stress, because maybe decreased cardiac output, and associations with resorption atelectasis, other respiratory complications. Actually, the evidence is not clear, and the recommendations recommend the lowest value to maintain good oxygenation. So SpO2 of 94%, that's the goal we should target. Okay. So now I think things are much clearer in these recommendations.
Okay, because I think now everybody has in mind the tidal volume and recruitment maneuvers, but the FiO2 maybe not. So thank you for highlighting this. And what about the other ventilator setting? I mean the ventilator mode, the pressure versus volume mode.
So in the latest recommendations, the experts could not recommend a mode over the other. So pressure controlled versus volume controlled, no specific recommendation. There are also contradictory reports on this choice. One advantage we could easily see in using volume controlled modes is that if you set an inspiratory pause time, you could easily monitor at least the dynamic plateau pressure, so dynamic compliance, and then easily estimate driving pressure. That could be very useful in our daily practice to adapt our settings of PEEP and see whether increasing PEEP, applying recruitment maneuver would result in recruitment. So basically decreasing increasing compliance and decreasing driving pressure.
Thank you. Last question, maybe very short answer about the COVID-19, because Mathieu Legrand has talked about this in the US. What's your opinion about the pulmonary complication during the pandemics?
Well, my opinion and some data, at least those from the COVID Surge Collaborative published in the Lancet, there was a multi-center observational study in patients undergoing surgery with and positive for SARS-CoV-2 with SARS-CoV-2 infections. Actually, they were, as we could guess, at a higher risk of developing complications, about 50% of post-op pulmonary complications in these patients, a higher risk of death, and like almost 30% in major surgeries of in-hospital deaths. So they are, of course, at higher risk, and they should be considered that they are critically ill patients with regards to the lung and their risk to develop pneumonia or ARDS. There's a 15% of risk of developing ARDS after surgery when you're COVID. And that's the same that any other risk factor for ARDS. So yeah, high risk and lung protection would be the key again, I guess.
Okay. Thank you, Mathieu.